Hello, good evening. Thank you, Dr. Hanadi and organizing committee for the invitation and kind presentation. I will talk about international changes in donor eligibility criteria regards risk of HIV and CJD. I have no conflict of interest. And we will talk about blood donor eligibility in brief, and then updates about changes and justifications in the donor eligibility for both disease, issues, CJD and HIV. Donor eligibility is made to maintain safety of patient receiving the blood and the donor giving the blood. And they start with proper donor reception, selection of donors, including donor questionnaires and health inquiries, including medications and health practice, and some physical examination, including weight, which has been omitted by some updated practice in some countries, and vital signs changes, blood donation collection, and then post-donation assessment. Blood donor eligibility criteria has been determined using multiple criteria over the years with the best current evidence and accumulative data of experience, some published researches and studies. And therefore, it varies across the world. However, most of them are almost similar and globalized, but the variation includes some medical, legal, and ethical or cultural community perspectives. And this includes epidemiology of some diseases, which are endemic in some areas and not in some other areas, include also changes in diagnostic methods of infectious markers, and they used the facilities being around the world for the testing and for the recruitments, and as well the health practice of the particular communities. The blood donation criteria are usually recommended through regional or national health authorities in the areas or the countries, and through approved bodies or societies or organizations like World Health Organization, ISPTs, and other, including American Association of Blood Bank or extra. The changes being adopted because with the time there are some changes in epidemiology or the practice, which will enable us to enroll more donors without compromising the safety of the blood components and therefore the safety of the recipients. Creutzfeldt-Jakob disease is a rare, fatal, degenerative disease of the central nervous system, part of transmissible spongiform encephalitis. It is a rapidly progressive disease presented with neuropsychiatric disorders. It has a very long incubation period, has been reported up to 25 years. However, it has a very short illness. Once occurred, it may be fatal within 4 to 5 months. And it is thought to be or expected to be due to Bryan disease. It could be, most of the cases are sporadic, and it happens 1 in a million case. And we have reported familiar Bryan disease due to mutations in Bryan genes. And then we have the iatrogenic CJD, which is less than 1% of the cases. It is reported in cases in patient has a dural matter transplantation, and in patient recipients of cadaveric pituitary human growth hormone from donors later on found to have the Bryan, affected Bryan genes. It's usually diagnosed through autopsy. However, there are some defined criteria and some screening tests, including protein 1433, and then some genes studies for the familiar disorders. So far, no report of transfusion-transmitted classical CJD However, there is confirmed cases of induced with growth hormone and urine matter transplantation. The variant CJD have shorter, relatively shorter incubation periods, up to 14 years. And it takes, once the illness occurs, it takes 13 or 14 years. Patient presented for 14 months, and patient presented with more of psychiatric disorders. It has been reported initially in 1996 in United Kingdom, and it is thought of as a disease by zoonosis due to eating the meat of infected animals, particularly cows. It's been improved, and there is a drop in the cases by implementing the proper strict control of food chain process in 1996. However, it is still reported. It was reported in some other countries like France, Ireland, and also in Saudi Arabia and some European countries. There been some evidence it's expected or thought to be transmitted through blood and organ donations. In United Kingdom, around 18 identified cases of CJD. They found later on they've been donors and have been traced to 67 recipients. 4 of these recipients were resident in United Kingdom also, and they developed CJD. 2 have been died later on in autopsy, have been found to develop the disease, to have the infected brain. So it was raising a question: is it a likely transfusion transmission, or is it because part of the being in the high-risk area? Most of the recommendations, and it's been implemented worldwide, is to use a pre-storage leukocyte reduction, as all of the cases reported before were transfused blood before implementing pre-storage leukocyte filtration. And there is, United Kingdom has restricted the use of plasma from their own donors, and it's been imported from UK, from outside UK. And then we have a permanent deferral for all patients, for all eligible donors were residing UK from 1980 to 1996, anytime for 3 months or more, or for 5 years or more in Europe or Saudi Arabia, 1980 to 2001. Any potential donors who's diagnosed or expected to have CJD or VCJD at any time, or have a relative, blood relative expected to have any of these diseases. In 2020, UK has made an assessment, and it's found that the risk is very, very minimum. And they allowed the use of UK for as a sourced plasma for immunoglobulins and others. And the health regulatory agency is recommending a very soon studies to may consider use of UK plasma for their own patients, considering the use of pathogen inactivation. And based on this published health risk assessment, so many other countries has followed the risk, including USA, which they removed the deferral from any potential donor who was residing in UK or France or Ireland in the high-risk period. This also extends to Canadian Blood Service, which allowed donors who've been residing in Saudi Arabia or Western Europe during the high-risk period, but is still not allowing any donor from who lived in UK in that particular period, 1980 to 1996. Australian Red Cross also allowed donors who lived 6 months or more from 1980 or to 1996 in UK to donate, and same extent to Irish blood transfusion. So our next discussion is about changes in donor eligibility in regard to HIV. So we know HIV can be transmitted through sexual or through blood transfusion or organ transfusion or through any blood contact through IV, drug use, piercing, tattoo, or through pregnancy. It is tested in blood donors using both serology and nucleic acid testing. For serology, we have antigen-antibody combo test, which is for B24 antigens together with IgG and IgM, HIV1 and 2 antibodies. And for the window periods, it's up to 45 days. So we may lapse 24 days to detect the infected donors. Antibody testing alone without the antigen is up to 90 days, and the same goes for rapid antigen. Nucleic acid testing can decrease the window period to 10 days. In regard to the summary of donor deferral for HIV risk, in the past, there was a deferral for high-risk sexual practice, or used to be thought it's a high-risk sexual practice of male sex with male. It was indefinite. And then we will talk about that. It was dropped to 12 months in some countries, and then 3 months, and now it's been implemented in countries with advanced transfusion medicine to be a defined time frame or individual risk. Female donors who had sex with a guy with the MSM also have the same deferral roadmap. Sex workers have been now, in some other countries, allowed a deferral notice of 3 months, and the same with people who has injection with drug use. These are summarization of what's happening in the world. It's not a recommendation, and it's not have been done in everywhere in the part of the world. Prospective donors who have tattoo or body piercing or cupping or hijama, they were deferred 12 months and then to 6 months, particularly in COVID era, and in some countries stopped to 3 months. And the same goes with any needle stick or surgeries or other contacts with blood. Potential donors who received blood transfusion, they used to be deferred for 12 months, and now we can have, or it's been recommended in some other countries, up to 3 months. There were some studies published between 2005 up to 2020, so many studies, and it shows that implementation of 12 months donor deferral for HIV risk practice shows no increase in the risk for blood component supply. However, the studies were raised from countries with a very good health practice and very good testing, and they have a centralized donor testing and donor database. And therefore, these countries has moved from 12 months to 6 months and then to 3 months deferral period. It has been recommended to have individual risk assessment, self-identified and self-reported for the donors. However, again, these donors are all volunteer non-remunerated donors, and they have very educational, very high culture of blood transfusion. So in USA in 2020, FDA reduced the deferral period for risk associated with HIV from 12 months to 3 months based on scientific published details. And in 2022, they are calling to re-evaluate the time-lapsed blood donation deferral period. In Canadian Blood Service, for the risk period for tattoo piercing has been dropped from 6 months to 3 months, and this, in 2019 have MSM deferral period reduced from 1 year to 3 months. The 3 months period has been put to guard against the window period, which was 90 days in some of the serological testing. And again, in 2021, there is ongoing studies to consider deferral based on risk, individual risk, and not for framed or fixed time period. Australian Red Cross and Brazil has, and some other countries like Greece, Spain, and France has been also dropped the fixed time frame for deferral for the HIV risk donors. So the contributing factor to consider for donor eligibility in case of HIV risk prospective, which could be at least looked from our side, is the donation is all are voluntary, non-remunerated donations, or we have replaced, some donors are replacing donation. Health education for the donors, including the sex practice and also the staff, blood donor staffing, who are supposed to be doing the interview. Do we have a national blood donors database so we would know who are the donors have been deferred from other centers and the reason for that? And also the centralization of the testing, or do we all use the advanced methods in our country? Ministry of Health, Saudi Ministry of Health has recommended to use individual NAT testing for every single donor, and also together with the antigen antibody combo test. So the current practice for HIV reduction is, for now, is 12 months deferral from the last events or contact of blood donors in our country. Usually for donors who have received money or drugs for sex, or intravenous or intramuscular drug users, or any sexual contact with high-risk persons. However, so far, most of the blood centers defer donors had MSM for indefinite. To my knowledge, Saudi Ministry of Health is discussing and evaluating all the updates, international updates in this regard, and maybe soon we will have some recommendations that match our culture and our health practice and our transfusion medicine practice in the era. For VCGD, we have universal leukodepletion, and then we still defer, or most of hospital defer donors who has been 3 months in United Kingdom in the risk period, or those spent 5 years or more in Europe during the 1980s to 2000s, or patients or donors who received blood at these countries at any time. Similar to international guidelines and recommendation, we permanently defer, or most of hospitals permanently defer any donors suspected for CJD, or they have blood relatives suspected for this CJD, or received any human-derived growth hormone or dura mater. So by this, I end the talk for international updates for HIV and CJD. And
thank you very much.
You're welcome.